I'd like to welcome everyone, and I do mean everyone. Well, if we're go- If you want a hearing, you better shut up. Okay, let's get.
Just let the police take care of it. Just let the police.
I will.
No cuts to Medicaid,
Save what?
save our Medicare care.
All right. I see. Where's the damn police? Get the police in here. How are you doing?
Can I observe today? Can I be
Oh,
an
yeah.
observant?
You sure can. That'd be great. Get the police in here. Get them out. They're not doing it. sitting through this one. Okay, the committee is in recess. The committee will be in recess until we get order.
space now for more.
No
Let's have order and let's show some respect here. Look, a lot of us are on your side, so just let's have some order. If you can't be in order, then get the heck out of here. Okay, the committee will come to order. I'd like to welcome everyone to this afternoon's hearing where we will discuss and examine the Graham Cassidy Johnson Heller health care proposal. Given the relatively unique circumstances we're facing with regard to health care generally, and this proposal in particular, the Senate Republican leadership as well as members of the conference have asked for a hearing on this proposal so that we can all get a better sense of how it is intended to work. Toward that end, we have two distinguished panels of witnesses before us today. The first panel will feature statements from two of our distinguished Senate colleagues. If the police would please remove that person, we'd appreciate it. And keep the doors shut. Okay, the second panel will feature another one of our colleagues who is also a member of this committee. We'll hear from a friend and former Senate colleague on the second panel as well. Joining them at the table will be experts and stakeholders who are here to share their views on the proposal from Senators Graham, Cassidy, Heller, and Johnson. The purpose of a hearing is to respectfully discuss ideas and become better informed on particular issues. The purpose of a hearing, as I've said, is to respectfully discuss ideas and become better informed on particular issues. It does not mean that everyone shares the same views and opinions. In fact, I expect that quite a few disagreements will be expressed today, and that's okay with me. I've been in the Senate for 4 decades now, and in that time I've been a part of some very difficult and contentious debates. Early on, I was part of a fierce debate over labor law reform. Over the years, I've participated in some of the most heated Supreme Court hearings in our nation's history. I was here to take part in drafting, debating, and passing the Americans with Disabilities Act, one of my proudest accomplishments. I was around when the debate over the war in Iraq became extremely combative. And of course, I was here when we debated Obamacare before it passed. And I've been here for every debate we've had about it since that time. So I've been through an awful lot of this, and it's nothing new to me. So I understand that there are some strong opinions about this issue. And more importantly, I understand why opinions are so strong. When we talk about health care policy, we're not just talking about a theoretical concept or legislation that impacts a single isolated industry. This topic has a significant impact on the lives of every person in this country in ways that can make or break both their health and their livelihoods. Frankly, because this issue is so personal, everyone has strong feelings on all sides of these issues. If we could shut that door and keep it shut, I'd appreciate it. To members of the committee, to those in the audience today, and to any person who may watch or read about today's hearing at some point in the future, let me say this. I respect your opinions on these issues, but while I wish that expressions of goodwill could on their own fix our nation's problems, that is just not the case. We have to do the work, and on these issues, the work is particularly hard. Today, we're here to discuss the most recent health care proposal drafted by some of our colleagues, and I commend them for their efforts and their willingness to put forward ideas to address these very difficult problems. My hope is that we can spend our time today questioning our witnesses about substance and policy, not on scoring political points, particularly when we have distinguished colleagues and a former colleague at the witness table. I know that for both sides of this debate, passionate demonstrations and righteous indignation, particularly when there are cameras in the room, make good fodder for Twitter and TV commercials, especially when the subject is health care. Our committee is generally regarded as being above such shenanigans, though we haven't been entirely immune to these types of theatrics in the past. For today, let me just say this. If the hearing is going to devolve into a sideshow or a forum simply for putting partisan points on the board, there's absolutely no reason for us to be here. I won't hesitate to adjourn the hearing if it gets to that point. It hasn't gotten there yet, but it's close. I'm saying this for the benefit of my colleagues on the committee and everyone in the audience. Let's have a civil discussion. I have no objection to having a spirited debate on these issues. My gosh, I was the author of the Americans with Disabilities Act, so I have very deep feelings about these issues. And I think most here on this committee have deep feelings as well. My hope is that in the end, our efforts will generate more light and less heat than we've seen in the most recent episodes of the healthcare debate. If we can't have that, we should all be spending our time on something more productive. So with that, and those few remarks, I now turn to our ranking member, Senator Wyden, for his remarks.
Thank you very much, Mr. Chairman. Mr. Chairman, I have an opening statement, and then at the conclusion of that, would like to bring up several points about the process, and I understand we've agreed to that.
That'd be fine.
Colleagues, nobody has got to buy a lemon just because it's the last car on the lot. This Trump Care bill is a health care lemon, a disaster in the making. The fact that it's the last Republican repeal bill standing doesn't make it okay. It's going to be a nightmare for tens of millions of Americans, and it makes a mockery of the president's promise of better insurance for everybody at lower costs. The bill's sponsors aren't even waiting for the official facts and figures from the independent scorekeepers. Version after version of this bill is floating around, and the pork parade is up and running. The process that has brought this Trump Care bill to the brink of passage would be laughable if the well-being of tens of millions of Americans wasn't in the balance. Now, I want to blow the whistle on a few key points at the outset. First off, the American people do not want this bill. In the last few days, the committee has received more than 25,000 comments from people who want it stopped. As with every other version of Trump Care, this proposal is about as popular as prolonged root canal work. There is one group cheering the bill on: the right-wing Republican donor class. The big donors want the entire Affordable Care Act thrown in the trash, and they've wanted it from the beginning. But it didn't work, since it turns out that it's bad policy to take health coverage away from tens of millions of Americans and raise costs for virtually everybody else. So the new strategy is essentially repeal by 1,000 cuts. It would be national repeal, and it would be state-by-state repeal. The heart of this bill is a scheme that punishes the states that have worked hard to build strong private markets and make health care more affordable. It rewards the states where lawmakers have sat on their hands, where they've spent years loudly rejecting the opportunity to improve the lives of millions of the people they serve. But that's not a proposition that gets much support. So instead, the committee today is going to hear a lot of hocus pocus about the word flexibility. The story goes, it's flexibility for the states, more control at the local level, and somehow everybody by osmosis is going to be better off. But let's be upfront about what it means in practice. The real flexibility created by the bill is the option for states to do worse, so that Americans are forced to pay more for less care. Now, off the top, this version of Trump Care guts funding for health care in the new block grants. Then governors and state legislators build new health insurance systems, and they're basically going to have to make Hunger Games choices, deciding which vulnerable people get care and which don't. The ironclad, loophole-free, guaranteed protection for those with pre-existing conditions will be gone. The bill sponsors will tell you otherwise, but colleagues, the facts are the facts. The guaranteed protection that nobody will be gouged due to a catastrophic illness like cancer will be gone. That's because the bill reopens the door to annual and lifetime limits on care. The guarantee of essential benefits, gone. That means prescription drug coverage is on the chopping block. Maternity care on the chopping block. Mental health and substance abuse treatment on the chopping block. And a whole lot more. The guarantee that nobody could be charged higher premiums because of their health status or their job, also gone. Bottom line, this bill is an all-out assault on vital consumer protection. It revives some of the worst insurance company abuses that were banned under the Affordable Care Act, and it's going to make the health care that many people need unaffordable. No, it does not adequately protect people with pre-existing conditions. What the bill does include are a few toothless lines about affordability and access. That's supposed to be protection, real protection for people with pre-existing conditions. But there's no enforcement mechanism, no tough standards, no real definitions. And the watered-down protections states put together for new insurance systems then can get a rubber stamp from Team Trump. Once again, in the Trump Care bill, there's an attack on women's health. Hundreds of thousands of women are going to lose the right to see the doctor of their choice. That's what you get when you defund Planned Parenthood. The traditional Medicaid program, a lifeline for people with disabilities, seniors and kids and pregnant women. Draconian cuts. An aging baby boomer who suffered a stroke might not get the help they need. The guarantee of nursing home care won't be there. The community-based program that offers care to people at home where they're most comfortable could disappear. Special education programs funded by Medicaid for vulnerable kids could be put in jeopardy. A few closing points, Mr. Chairman. The process that has led to this moment has been an abomination. And we've just seen, colleagues, some of the frustration that our people have at closed-door government that locks Americans out of the democratic process. This just isn't serious. It's really a talking point today. It's a scheme to let senators go home to fearful constituents and offer assurances, false assurances, that this bill got a fair examination and went through the regular order. It's not true. Senate Republicans haven't gotten answers to the most basic questions about the real-world effects of the bill. How many people are going to lose coverage? By how much are premiums going to increase? Will the health care market survive next year? The independent scorekeepers at the budget office say it's going to be several weeks before they can put forward estimates of coverage and cost. And their job gets tougher because this bill just changes by the hour as the majority throws around in the scramble for votes. Why the rush job? It's because the coach turns back into a pumpkin at the end of the month. That's when the reconciliation fast track to pass the partisan bill expires. Now, we want to be clear. On this side, we think we ought to be working on bipartisan priorities. We've got a good bill for kids, children's health insurance plan, 9 million kids. The funding for that program, colleagues, runs out in just a few days at the end of the month. We'd like to be working on that in a bipartisan way, and we'd like to be working on stabilizing the private insurance markets. I heard about that this weekend at town hall meetings in Central Oregon. That's what we want to work on. We want to do it in a bipartisan way with our sister Senate committee. Instead, what's on offer is this Trump care bill that's going to trigger a health care disaster, a death spiral in the insurance markets as tax credits and cost-sharing payments go away and healthy people flee and costs go into the stratosphere. Democrats on this side of the dais want to continue to do everything, one, to stop this dreadful proposal from becoming law, and two, to get down to the serious, heavy lifting of passing bipartisan legislation for kids, number one, and for adults in the individual insurance market. Now, with that, Mr. Chairman, I'd like to just wrap up with a few quick points about the procedure for this hearing. This is per our agreement. First, Mr. Chairman, I think you know that we're very disappointed in the response to our request to hold this hearing in a larger room that could accommodate more members of the public. I'd ask unanimous consent that a letter outlining this request be included in the record.
Without objection.
This is the first and only hearing that will be held regarding a bill affecting more than 320 million Americans and 1/6 of our economy. As we just saw, there is enormous public interest. We've seen hundreds of people today, many in wheelchairs, lined up in the hall, hoping to get into the hearing. However, after you take account of the committee members, staff, witnesses, and members of the press, the room we're in only has space for about 30 members of the public. 30 for a hearing of this import. Normally, when Congress holds hearings that attract such enormous public attention, we have our hearings in large hearing rooms, the largest hearing rooms, to accommodate hundreds of audience members. My understanding is those rooms are available today. So the question I really have is, why not move the hearing there so more people can attend? Otherwise, it sends yet one more signal that the majority wants to keep the bill under wraps rather than opening up the process to the American people. Finally, Mr. Chairman, I understand that Senator Cassidy wants to participate in this hearing both as a witness, providing testimony, and as a member of the committee, asking questions of the same witness panel he is part of. I expect we're going to hear a lot today from Senator Cassidy about flexibility. I gather he's a big fan of flexibility. He appreciates flexibility so much he wants to apply it to himself. However, to my mind, dashing back and forth between the witness table and the dais is not proper decorum for a hearing. So I would just like to make clear, Mr. Chairman, because my understanding with respect to the rules is I have to leave it at that. I sure think it's more appropriate that Senator Cassidy wears one hat during this hearing rather than two. Thank you.
Well, thank you, Senator. I think Senator Cassidy ought to be able to do what he wants to do, but I'll make sure he doesn't ask questions of himself.
Interesting.
Well, maybe I better withdraw that. Appreciate your kind and good remarks. Now, because of the high interest and the importance of this hearing, an overflow room has already been secured. Not to mention it will be televised on C-SPAN and available for live streaming on the Senate Finance Committee website. To my colleagues' complaints about the process for setting up this hearing, I'll just say that many senators have expressed a desire to examine details of the proposal we're discussing today. Today's hearing is being held to allow members on both sides to delve deeper into the policy and gain a better understanding of what our colleagues' proposal hopes to achieve. I do not expect this hearing to go on forever, but we'll give certainly good opportunity. Now, I would like to welcome each of our witnesses to our hearing today. To start off on the first panel, we will hear from our good friends and fellow senators, the senior senator from South Carolina, Lindsey Graham, who is the co-author of this bill, and the junior senator from Hawaii, Mazie Hirono, for opening remarks. We are grateful to have such passionate and wonderful senators join us today to share their views. Senator Graham, will you please share with us your remarks, and then we'll go to Senator Hirono.
Thank you, Mr. Chairman. First remark I would like to share with you is why I'm here. I'm here because Obamacare is a disaster in my state. It's not your job to take care of South Carolina, it is mine, and I intend to do that. Maybe we'll find a common way forward. I don't know, but I'm not going to be deterred.
But I intend to help.
Thank you.
Put it that way.
In 2014, there were 5 insurers offering plans to South Carolina customers under the exchange. Today, we're down to 1 with a 31% increase announced Friday. If you expect me to walk away from that, you're sadly mistaken. I don't know how it's working in your state, but in my state, it's a disaster. Why are we in finance? Because health care really does affect federal finances. Most of you know that by 2042 that the entire revenue stream will be consumed by Medicare and Medicaid spending unless somebody does something about it. There'll be no money for the military, the Department of Education, NIH, or anything else. So what do? I deal with 2 problems. Nationally, Obamacare premiums are going up 13% in the individual market. 45% of the counties in America are down to 1 choice, and 45 counties in this country have no choice under the plan you designed. The bottom line is I don't doubt your intention to help people. I do question whether or not it is working as intended, and you can question my motives, and quite frankly, I don't care because I know why I'm here.
You're saying who designed it? It wasn't mine.
Well, I know, Mr. Chairman, it wasn't. So we got 2 problems. If somebody doesn't fix Obamacare soon, the majority of counties in this country are going to be down to 1 provider. It is collapsing as I speak. Medicaid. Medicaid is on an unsustainable path. By 2027, we're going to be spending more on Medicaid than the military. By 2042, Medicare and Medicaid combined take all the money that's going to be sent to Washington taxes. And what do? In year 8 of the block grant, We give flexibility and control to the states over the Medicaid program like they haven't had before, but they have to spend it on the population in question. We begin to slow the growth down to make it more sustainable, but the flexibility we give will allow us to get better outcomes. Medicaid spending and Medicaid outcomes are not matched up to where anybody should want them to be. When it comes to Obamacare, if you don't find a way to stop the bleeding, then it's going to basically collapse before our eyes. And here's what we do. I'm getting a lot of pushback from my Republican colleagues because I leave the taxes in place. Here's the idea of Graham Cassidy, Heller, Johnson. We repeal the individual mandate and the employer mandate, but you can reimpose it in your state if you like. If you want to go to single-payer health care, you can do it in Oregon, but you're not going to drag me with you. So here's the deal. We leave the taxes in place. It's $1.2 trillion, and we block grant it out to the states in a formula that I think is fair. Under Obamacare, between 20 and 26, 4 states get 35.4% of the money. They're Maryland, Massachusetts, New York, and California, and they're 22% of the population. Good deal for them, not so much for the rest of us. Under this block grant, they get 29%, not 35%. Still more than the population. What have I learned? Hawaii is a very expensive place to provide Medicaid. It's a very expensive place to provide health care. It's just a very expensive place to live. Alaska has 750,000 people, 2.5 times the size of Texas. Under this bill, we look at you. Rather than some bureaucrat in Washington who has all the money and the power, we're going to turn it back to you, your state legislature, and your governor. And I asked the following question at a lunch not long ago. How many of you know your state house member? Almost everybody raised their hands. How many of you know the governor of South Carolina? Everybody raised their hand. I asked the question, how many of you know who's in charge of Obamacare in South Carolina? Nobody raised their hand. And that is the problem. We're going to send this money back to the states. You can't spend it on roads and bridges. You got to spend it on health care. You're going to have flexibility, but you're also going to have accountability. And for the first time in health care, somebody's going to listen to you. Because if you don't like the health care you got, you can complain to somebody you vote for. The model you've created is never going to work. As to the opposition to this bill, to the ranking member, every major insurance company opposes our bill. Why? Because we take hundreds of billions of dollars away from them that were going to them from the federal government and give it to the states. Guess what? They don't like that. If I were a major insurance company, I'd hate my bill because I take money and power away from you and I give it to the states. Washington is wired when it comes to health care. Everybody opposing this bill is a big winner of Obamacare, and my goal is to get the money and power out of Washington closer to where people live so they'll have a voice about the most important thing in their life. I don't need a lecture from anybody about health care, but what you have created is not working. It's time to try something new, and I believe with all my heart and soul, Mr. Chairman, that if we took the money and power out of Washington, we got it closer to the patient, we put it in the hands of somebody you would have a relationship with, and you could actually vote for if you don't like the product, we're going to get a better outcome. And this is not the last chance. This is the best chance. And to my friends to the left, I will do everything I can to stop and put a stake in the heart of single-payer health care. You don't like Obamacare. You don't think it's big government enough. I'm here to stop you. You care as much as I do about health care, but going beyond Obamacare is a nightmare for this country. It will ruin health care and bankrupt the American people. And this is a debate worth having. Thank you very much. God bless you all.
Well, thank you, Senator Graham. Senator Hirono will please proceed with your statement now.
Thank you, Mr. Chairman, and Ranking Member Wyden and all of the members of the committee. Thank you for inviting me to testify. When I was diagnosed with stage 4 kidney cancer about 5 months ago, 2 things. The first was the diagnosis came as a total shock to me. It came about incidental to a physical checkup that involved an entirely different procedure that I was facing. This is how a lot of people learn about a serious illness or condition. Out of the blue, bang. They can't plan for it. Second, I received letters, cards, and notes when people found out. I was touched by the hands reaching out to me, the show of compassion, including from so many of my colleagues, including members of this committee on both sides of the aisle. Every day now, people come up to me at airports, grocery stores, restaurants, to tell me that they too are cancer survivors. There is a connection there. It is never a good time to have cancer, but what I am experiencing through my cancer is the care and concern expressed by total strangers. This is compassion. It helps me a lot. What we do as leaders affecting everyone's lives should reflect compassion. Sadly, that's not in this bill. In the greatest, richest country in the world, compassion for our fellow men and women should not be so elusive or indeed missing. After all the compassion and care that I received from my colleagues after I disclosed my diagnosis, the Graham Cassidy proposal reflects neither care nor compassion for millions across the country. Health care is a right. It is a right. It is not a privilege reserved for those who can afford it. But Graham Cassidy treats health care like a commodity that can be bought and sold. This is fundamentally wrong. Although nearly all of us will face a serious illness during our lifetimes, it's almost impossible to budget and plan for the costs associated with treating it. And once you're diagnosed, you can't just put off treatment because you can't afford it. Before the Affordable Care Act, catastrophic health care costs were the largest driver of personal bankruptcies in the country. And since the law went into effect, we've seen a huge reduction in personal bankruptcies. There is a causal relationship when people get health care. If you dig into the details and numbers, it's clear this bill is much worse than the bill we defeated in July. Under the thin veneer of states' rights and local control, the Graham Cassidy bill imposes a radical overhaul on one-sixth of the American economy. According to the Brookings Institution, 32 million people will lose their health coverage under it. There's so much wrong with this bill that it's difficult to confine my remarks to only the short time I've been allowed to testify. Contrary to promises made by the bill's authors, this proposal undermines protections for the close to 600,000 people in Hawaii and 134 million people all across the country living with pre-existing conditions. This bill seriously undermines consumer protections that require coverage for pre-existing conditions and prohibit insurance companies from charging sick people more for care, which is exactly what they will do, believe me, if this bill passes. The process requires a pro forma explanation of how a state would maintain coverage for those with pre-existing conditions. But it's really a box that they just check off. There's nothing here that ensures the level of protection that the Affordable Care Act does. Sure, the federal government can deny a state's waiver application, but the very people who would be making this decision at the federal level are longtime opponents of the Affordable Care Act. Sadly, the American people cannot trust this administration to do the right thing regarding their health care. We don't have to look back far to see what the result would be if a state granted a waiver. Insurance companies could use age, health status, and other factors to determine what premiums to charge. They could set annual and lifetime limits on care and could refuse treatments because of how much they cost. Believe me, I have a complicated illness, and I would reach lifetime limits in practically a nanosecond. I intend to live a lot longer before that day comes. Under this bill, coverage might be available, but it would be prohibitively expensive and able to be taken away in someone's moment of greatest need. This bill dismantles Medicaid as we know it. The bill converts Medicaid into a block grant to states and cuts its funding by hundreds of billions of dollars by 2026. It punishes states like Hawaii that expanded Medicaid by cutting federal funding and redistributes it to those states that did not expand Medicaid, and therefore hundreds of thousands of people in those states don't even have the kind of coverage that Hawaii provided. For Hawaii, we're looking at around $4 billion in cuts and 91,000 fewer Hawaii residents having health care because of this bill. Because states would receive so much less money, they will no longer be able to provide quality, adequate care for as many people as possible. Instead, they will face the impossible task of choosing who should lose insurance and which services to cut. Even then, the most vulnerable members of our society, the elderly and the disabled, children, will not receive the care and services they need. Mr. Chairman, we are all one diagnosis away from a major illness. I certainly found that out. With so much uncertainty right now in our country, the one thing that people should be able to count on in the richest country in the world is getting the care they need when they need it. Healthcare is a right, not a privilege for those who can afford it. Healthcare is personal to every single one of us. I'd like to conclude with a call to action. This bill would be devastating for millions of people across the country facing dire health consequences. Millions of lives are at stake. Let's return to the bipartisan negotiations led by Senators Alexander and Murray to stabilize the health insurance marketplace. And this is something they are doing together in a bipartisan way. This is exactly how we should approach healthcare in our country. Focus on the people we are elected to serve. Focus on the people we are elected to serve. Show them the compassion that they are expecting from their leaders. They expect us to work together and come up with a bill that we can get behind. Thank you, Mr. Chairman.
Well, thank you, Senator Hirono. We appreciate your remarks. Thanks to both of you for sharing your remarks to the committee today. I think I speak for all of my colleagues when I say that we are hopeful and praying, Senator Hirono, for your quick and total recovery from cancer. We do appreciate both of you for taking the time to be with us today. You are both welcome to stay for as long as you wish. Now we're going to turn to panel 2. Next, we will hear from the 6 witnesses that sit before the committee today. I will introduce witnesses briefly and then have each of you provide your testimony in the order you are introduced. First, we will hear from our good friend, colleague, and fellow committee member, the Honorable Dr. Bill Cassidy. Prior to his coming to the Hill in 2015, Senator Cassidy provided care for uninsured and underinsured patients for nearly 30 years. He is a co-founder of the Greater Baton Rouge Community Clinic, created a private-public partnership to vaccinate children against hepatitis B, and in the wake of Hurricane Katrina, he led a group of healthcare volunteers to convert an abandoned Kmart building into an emergency healthcare facility. Senator Cassidy has also taught at the LSU Medical School and is a former member of both the Louisiana State Senate and the U.S. House of Representatives. Senator Cassidy attended the Louisiana State University for both his undergraduate and medical degrees. Secondly, we will hear from our good friend and former colleague, Senator Rick Santorum. Former Senator Santorum served in the U.S. Senate from 1995 to 2007, prior to which he also served in the U.S. House of Representatives from 1991 to 1995. Senator Santorum and his wife Karen are also co-authors of the best-selling book, Bella's Gift, How One Little Girl Transformed Our Family and Inspired a Nation. Senator Santorum received his bachelor's degree from Penn State University, his MBA from the University of Pittsburgh, and his law degree from Dickinson School of Law. Next, we will hear from Mr. Dennis G. Smith, the Senior Advisor for Medicaid and Healthcare Reform at the Arkansas Department of Human Services and a visiting professor at the University of Arkansas Medical Sciences College of Public Health. Mr. Smith has spent most of his career in public service. At the federal level, he has worked in both the executive and legislative branches, including 10 years on Capitol Hill and 10 more years at the U.S. Department of Health and Human Services. In fact, Mr. Smith headed the Medicaid agency for nearly 7 years, the longest tenure of any Medicaid director at the federal level. Mr. Smith also worked in both the U.S. Senate and the U.S. House of Representatives from 1989 to 1998. Our fourth witness will be Ms. Teresa Miller, the Acting Secretary of the Commonwealth of Pennsylvania's Department of Health and Human Services. Previously, Ms. Miller served as the Pennsylvania Insurance Commissioner from January 2015 through June 2017. Additionally, she chairs the Senior Issues Task Force and its Long-Term Care Innovation Subgroup at the National Association of Insurance Commissioners, or NAIC. Prior to her work in Pennsylvania, Ms. Miller served as Acting Director of the State Exchanges Group, the Oversight Group, and the Insurance Programs Group in the Centers for Medicare and Medicaid Services at the U.S. Department of Health and Human Services. She also served as the Administrator of the Oregon Insurance Division. Miller received her JD from Willamette University College of Law and her BA from Pacific Lutheran University. Next, we will hear from Ms. Cindy Mann, the former Deputy Administrator and Director of the Center for Medicaid and CHIP Services at CMS. Prior to her appointment at CMS, Ms. Mann was a research professor at the Georgetown University Health Policy Institute. There, she was the founder and director of the Center for Children and Families. Ms. Mann also previously worked as a senior advisor at the Kaiser Commission on Medicaid and the Uninsured. Ms. Mann is now a partner with Manat Health. Cindy received her JD from New York University School of Law and her BS from Cornell University. And last but not least will be Mr. Dick Woodruff, Senior Vice President of Federal Advocacy for the American Cancer Society, Cancer Action Network. Altogether, Mr. Woodruff has more than 35 years of experience in Congress, the executive branch, and the not-for-profit world, including serving as a Chief of Staff and Legislative Director for members in the U.S. House of Representatives, as well as the Senate. He also served as the Director of Congressional Affairs at the National Endowment for the Arts. Mr. Woodruff is a graduate of Miami University in Oxford, Ohio. I want to thank each and every one of you again for taking time out of your busy schedules and coming here today. And I look forward to hearing every one of your remarks. Senator Cassidy, will you please get us started?
I cannot tell you how honored I am to testify before my colleagues. I respect you so much. You're knowledgeable and you're passionate about health care. You're knowledgeable and passionate about our country. I hope that you accept that I also have studied health care and am passionate about it, and am passionate about caring for the uninsured. My work for 30 years in public hospitals in California and in Louisiana was spent caring for those who have less. Let me say first, Senator Wyden, I am so sorry about this process. I would have preferred hearings, a markup, a Democratic co-sponsor. For 3 years, I've gone around to Democratic colleagues, several in this room, have met with you and asked, could we please work together? Susan Collins and I came up with legislation which was so bipartisan, in which a state like Oregon could keep Obamacare if they wanted. If it's working for you, that's fine. But in my state, the individual market is collapsing. In Tennessee, it's collapsing. I could go down the list. Allow us to do something different. It was praised by both the left and the right that this was a bipartisan attempt, sincere. All 10 said they could not help. Now, after the health care vote failed in August, I was assured that now bipartisan cooperation would begin. That has not happened. In the meantime, the individual market in my state is collapsing. If you're not getting a subsidy, you can't afford your coverage. There was a friend, I put it on my Facebook page, no one believes me, and he's paying $39,000 a year for his premium. People ask us, wait a second, how do you ensure affordability? Is $39,000 a year affordable? That's not including his deductible. So when I ask people, will you help me? 3 years I've been doing this, and for 3 years I was basically told, nice try. I'm then presented a choice. Do I say I'm not going to help, people won't help me, so I quit trying to help those folks who cannot afford policies in my state? That's not why I was sent here. I was sent here to work for them, and if this is the only means by which I shall do so, I can do so, then I shall. Now again, before being Senator Cassidy, I was Dr. Cassidy, caring for the uninsured and Medicaid patients in Louisiana's public hospital system. My patients had terrible diseases, multiple chronic conditions, and I did my best to serve my fellow Americans. I truly believe that Graham Cassidy Heller-Johnson serves these fellow Americans by other means. The ACA promised affordable health care coverage, freedom to keep your doctor, and to keep health care costs down. In reality, on the exchange, middle-class families have skyrocketing premiums, individual mandates that they hate, $6,000 deductibles, with cost inflating and doubling in 2 short time frames. Indeed, if there's one thing we can agree on a bipartisan basis, Obamacare is failing. 15 Democratic senators recently declared such while endorsing a single-payer system. The problems of Obamacare require a path forward. On a positive note, I was presiding the other day when Senator Wyden was praising the CHIP program. We agree. Graham Cassidy Heller-Johnson passes a flexible block grant through the CHIP program, keeping the protections and the requirements of the CHIP program. We combined the Medicaid expansion dollars, Obamacare, tax credits, the cost-sharing reduction subsidies, the basic health plan, and distribute it in this means. By the way, it's a mandatory appropriation, and yes, the CHIP program requires reauthorization. This will too, but it doesn't mean the money goes away automatically in 10 years, as some have absurdly stated. Let me address the inevitable comment. Oh, by the way, we don't affect 6% of the economy. That's a misstatement. We're not touching Medicare, employer-sponsored. We're not touching employer-sponsored insurance. We're not touching TRICARE. None of that is touched. We are in the individual market. We are in the Medicaid expansion and traditional Medicaid. This is not 1/6 of the economy. There'll be the inevitable comment that we're ending Medicaid expansion. Actually, a state could take the dollars that we're giving and continue the expansion program as they have it now. They have the flexibility. I can tell you, despite me pointing this out, it will be said. To help states, many of which are not able to meet their expansion match in 2020, the Medicaid expansion match is waived. The flexible block grant functions like a combined 11-15-13-32 waiver. We preserve protections like mental health parity, guaranteed issue, prohibit charging women more, no lifetime caps. States applying for waivers must prove that the Americans with pre-existing condition have access to affordable, adequate coverage, period, the end, and you define affordable as able to afford. Contrast that with $39,000 a year premiums. This raises an issue, perhaps to end here. Many on the left are threatened that we give states and patients the power that Obamacare usurped. Under this narrative, states are inept, corrupt governors scheme to deprive the citizens of their state of protections, and patients only get better if told what to do. This amendment rejects that narrative. And by the way, partisan, Virginia gets $4 billion more dollars. Florida, $15 billion more dollars. Missouri, $5 billion more dollars. Increasing access to cancer screening and cancer treatment for folks in those states who currently do not have. I wonder if those opposing this amendment care about those in that state. Because right now, those in Virginia will have more for these tests. We need to pass Graham Cassidy, Heller Johnson, returning power to patients, states, while expanding access to coverage for millions. Thank you.
Thank you, Senator. Senator Santorum.
Thank you, Mr. Chairman. It's an honor to be here before my former committee, and I'm here because I'm a father of a child who, like many outside this room, is in a wheelchair because she can't walk, and she can't talk either. So I'm trying to speak for her and for others like her. I see the hysteria that has been developed around this bill, and it's really disturbing to me that what is a clearly responsible proposal that, as many on the right have criticized, keeps 90% of the taxes and 90% of the spending, is going to cause everybody who was ever covered by Obamacare to be without insurance. That just doesn't make any sense. It is irrational. It's not supported by any facts or any of the evidence. And it just shows the frustration that many Americans have as outside of Washington in seeing something put together by, let's just say, not two of the most conservative members of the Republican caucus, Lindsey Graham and Bill Cassidy, who sponsored a plan with Susan Collins to try to get bipartisan support. These are the sponsors of this legislation, people who are not on the far end of the Republican Party, yet it's being treated as this draconian slashing. This is not the first time that I had experience with this type of reaction to a change in entitlement programs. 21 years ago, I was in the United States Senate and had the privilege of managing the bill on the floor of the Senate to reform welfare. The very same organizations and groups that are out in the halls and others complaining about this bill were saying that people would be sleeping on grates and bread lines would be redeveloped and we would be cruelly cutting people off all of these services that they so badly needed. The reality is that we are doing the same thing in this bill as we did in 1996. That's the idea. When I talked to Lindsey and Bill and others about this idea, was based on the success of the 1996 welfare law, a bill that got bipartisan support. Even though there was hysteria, there was a recognition that this program was not doing as well as it could be, and that there were innovations at the state level that could be replicated and done better, to care for people better, to get people off of welfare, that we shouldn't measure the success of welfare as to how many people are on it, but how we transition off and get to work and how we lower poverty rates. And the same is here. It shouldn't be how many people we're getting into a government program, but how much affordable insurance we're providing for an entire market, like myself, who's on the Obamacare exchanges and pays around $30,000 a year for our policy. Now, I don't know how families do that. I mean, that's, to me, the idea that this is affordable is ridiculous. It's not affordable. And so I came forward based upon the information that I had and experience I had in working on welfare, and suggested that we can do the same. And I did, by the way, with welfare, when I was on the committee and even before, I had 9 people in my office that I hired who were former welfare recipients. I take this responsibility of getting engaged and involved in public policy, whether in office or out, that the primary purpose here is to make sure we have a system that works well for America. And the hysteria that's being developed here on a bill that candidly is modest in its reductions in spending, modest in its reductions in taxes, and even modest in the flexibility that we give to the states outside of the ACA to be able to provide care for those who are in need in our society who fall through the cracks. This legislation is in 2 parts. One is a block grant of the ACA monies, as Dr. Cassidy described, and the other is the Medicaid per cap. As everyone knows, the Medicaid per cap was proposed by President Clinton. Now it's seen as this draconian measure. The Medicaid per cap ties the rate of growth, per capita rate of growth of Medicaid at around the level of medical inflation. Now, we have advocates who have gotten up and said we need government-run health care for everybody, and that's the most efficient and effective way. Yet, when we put the cap on health care, on Medicaid, at the rate of inflation for health care, we're told that this government program will collapse. How can you have it both ways? That government health care is the most efficient, but if you put it at the rate of medical inflation, which includes all these, quote, inefficient private plans, you're going to collapse? You can't make that argument. You can't say you're the best, but you can't keep up with inflation. On the second block grant, it's very simple. We give states an enormous amount of money. People say, well, this would be going back to the old system. The old system didn't have $1.2 trillion to be spent by the states to be able to make the system work. I look forward to the opportunity of getting into the details of how we designed this to make sure that states who expanded Medicaid are not disadvantaged over the long term, that we gradually ramp down ramp in the formula, that we do a lot of things that Dr. Cassidy and others have worked on to make sure that this is a fair system, that all poor people in America and those in the individual market get the opportunity to get some help from the federal government so we can have affordable and stable insurance markets. Thank you, Mr. Chairman.
Well, thank you. That was very, very interesting as far as I'm concerned. Let's turn to you, Mr. Smith, and take your testimony at this time.
Thank you very much, Mr. Chairman. It's a privilege to be with all of you today, and I'm here to discuss the Graham Cassidy Heller Johnson Amendment. And I'm also pleased to convey Governor Hutchison's support for this proposal, as we believe that it makes a great deal of sense that will protect interests of individuals on Medicaid, as well as those who are subsidized in the private sector as well. In 2017, CBO estimates that on the Medicaid expansion, the premium subsidies, the tax credits, the cost sharing, will spend about $111 billion, the federal government. 2026, under the proposal, it'll be $190 billion. That's a 70% increase in the amount of federal spending available to provide the coverage. In the original estimates, the Congressional Budget Act, Congressional Budget Office, when it modeled the Affordable Care Act for what the coverage would look like in 2017, in this year, so they modeled it 7 years ago. What they predicted then was very much inaccurate, in that CBO had in its baseline by 2017 there'd be 35 million non-elderly individuals on the Medicaid program under the current law baseline. And under the Affordable Care Act, 15 million would be added to that number. And if you recall, that is when Medicaid expansion was mandated under the legislation, which of course turned out not to be true. Today, we have 69 million non-elderly individuals on Medicaid and CHIP, of which 13 have been made eligible by the ACA. So the individuals that CBO predicted would be receiving subsidies over in the marketplace, in fact, are in Medicaid instead. This legislation puts those two populations together. So again, now we would form a pool of 22 million lives, of which are relatively young and healthy, and that would be the new pool. Again, everyone keeps talking about how do we stabilize the premiums for this population. We keep trying to throw more money at it. Well, the solution is put more people into it. That's what will truly stabilize the pool. Also have my remarks on the CHIP program. Again, I was privileged to be 20 years ago with Chairman Hatch and Senator Grassley at the time to help create the CHIP program. So I believe it is a great vehicle to use for that purpose, to build upon that. And it has the benefits of having a structure already in place. CHIP is a very popular program. People know what it is, but it is also a capped allotment to the states. It is flexibility to the states. It is deferring to the states on many of the decisions that have been made. And I would suggest CHIP has been wildly popular on a bipartisan basis for 20 years. The third point I wanted to talk briefly about is per capita caps in Medicaid. We already have per capita caps in Medicaid. Virtually every state that has an 1115 waiver agrees to a cap on the amount the federal government will give to that state to live under that waiver, including states of Arkansas. We are living under a per capita cap. If we exceed that cap, then we are at risk for every dollar above that cap. States will manage the programs to those caps. Those caps, by the way, the Office of the Actuary now produces an annual report on Medicaid spending. And in 2015, the actuaries made their projections out through the year 2024 for what Medicaid was going to be spending. Last year, they reduced their projected spending for Medicaid by $140 billion. Nobody is arguing that there is somehow $140 billion has been lost. You've revised the baseline. The baseline changed. In many respects, the baseline is changing. It is lowering because the states do not have their share of the funds to be able to continue to accelerate Medicaid spending at the rate it is. So the medical price, the consumer price index of medical inflation +1 for the disabled and elderly populations that the bill provides for, that the proposal provides for, when you look at the actuary's report, that is a higher growth rate than what CBO is estimated that its per elderly and disabled beneficiary will grow by. So again, the reality is slowing on a spending on a per beneficiary basis is lower than what the bill is providing for. The last point on work requirements, which is a feature of the bill, again, we have passed, with the Governor Hutchison's leadership, passed work requirements which received overwhelming bipartisan support in Arkansas. Again, I think that this is a vehicle that states will be able to readily adapt to, will be ready to put into place, and will continue the tradition of this committee in extending coverage to the most vulnerable Americans.
Well, thank you so much. Ms. Miller, we'll call on you now.
Good afternoon, Chairman Hatch, Ranking Member Wyden, and members of the committee. I sit here today honored to have this opportunity, but also very, very concerned about the potential for this legislation to become law and what that will mean for the millions of Americans who rely on the Affordable Care Act for quality, affordable health insurance. Since passage of the ACA, Pennsylvania is experiencing an all-time low uninsured rate. We just announced that we've gone from over 10% uninsured before the ACA to 5.6% today. As we face an opioid epidemic that is devastating our communities, 175,000 people have been able to access substance abuse treatment thanks to the ACA and Governor Wolf's Medicaid expansion. I could go on and on about all the benefits people in Pennsylvania and around the country have realized because of the ACA, but it's also important to point out that the ACA is not perfect. I had the opportunity to testify a few weeks ago before the Senate Help Committee about ways that we could work together to stabilize individual markets, which is really the limited area that needs attention. A group of insurance commissioners from red and blue states alike talked about targeted reforms that could be put in place to stabilize our markets to ensure the ACA works for everyone going forward. I was optimistic after that hearing because for the first time in this debate, it appeared that senators from both sides of the aisle were genuinely interested in focusing on the problem, the need to stabilize the individual market, and finding a solution to that problem, rather than using the problems in the individual market as an excuse to repeal the ACA entirely, and as the National Association of Medicaid Directors put it, make the largest intergovernmental transfer of financial responsibility from the federal government to states in our country's history. And yet now, I find myself here again talking about a proposal that would make draconian cuts to Medicaid and force governors across the country to make the most gut-wrenching decisions they can possibly face. According to an analysis by Avalere Health, Pennsylvania would lose $15 billion in federal funding in the next decade. Kaiser Family Foundation put the number at $22.7 billion. Our own analysis estimates we would lose $30 billion, assuming average cost growth. This forces governors across the country to make impossible decisions. Who should receive health care? A child born with a disability? A young adult struggling with an opioid addiction? A mom fighting breast cancer? A senior who's worked hard all his life and needs access to quality health care to age with dignity? Having been a state insurance regulator in 2 different states and having spent time as a federal regulator, I truly believe states are in a better position to make decisions impacting our residents. We know our markets better, we're more nimble and able to respond to issues impacting our consumers. So when we hear that you want to give us more flexibility, you do pique our interest. I gave the Senate Help Committee some ideas for ways the federal government could streamline the 1332 waiver process and make it easier for states to get these waivers. But cutting billions of dollars from Medicaid and giving states reduced funding in the form of block grants, funding that goes away after 7 years, is not the kind of flexibility that we're looking for. I've been thinking a lot over the past few days about what we would do in Pennsylvania if this bill becomes law. And honestly, I am really struggling to figure out how we would respond. We would have 2 years to completely revamp our healthcare system, work with stakeholders to figure out what a new system could look like, develop whatever infrastructure would be needed, make system changes required, pass legislation, get any necessary federal waivers, and a host of other activities. All of this would need to happen apparently without federal funding to support these essential planning activities. The ACA gave states almost 4 years and a lot of funding to support their work. Oh, and after 7 years, the funding disappears and the state would be left holding the bag to fund whatever system we put in place. That alone makes it highly unlikely we would get anything in place in Pennsylvania by 2020. In my experience, state legislatures, they don't want to put a system in place with federal dollars if we don't have a way to ensure it's sustainable after we lose those federal dollars. But let me be clear. Providing implementation funding or extending this funding indefinitely into the future would not fix the insurmountable flaw in this bill, the staggering cut in federal funding. Pennsylvania is facing a $2 billion structural deficit in our budget now. We don't have a balanced budget for this current fiscal year 3 months into it. And we certainly don't have the ability to cover the loss of anywhere from $15 to $30 billion in federal funding over the next decade. We have had less than 2 weeks to analyze this bill, a bill that would have a devastating effect on the more than 3.2 million Pennsylvanians with coverage through Medicaid and on the federal exchange. Please don't paper over these draconian spending cuts. which will inevitably increase the number of uninsured under the guise of state flexibility. On behalf of Pennsylvanians, on behalf of children, seniors, individuals with disabilities, our most vulnerable populations, I implore you to return to the bipartisan process that the Senate was engaged in earlier this month and craft a compromise bill to stabilize the individual market and improve our current system. Thank you.
Thank you. Ms. Mann, we'll turn to you now.
Good afternoon, Chairman Hatch, Senator Wyden, and distinguished members of the committee. This nation has made enormous progress, increasing the number of people who have health insurance and moving health care to a system that provides greater value with lower total costs. But we still have a long way to go. Virtually every major health care provider and health plan association and consumer group, from the AMA, the American Hospital Association, and AHIP, to the American Cancer Society and the American Academy of Pediatricians, those are just some in the A category, have voiced opposition to the Graham Cassidy proposal. None of these groups, however, would say that there isn't a need for ongoing reforms and improvements in our healthcare system. Graham Cassidy, however, would inevitably take us backwards and in a reckless and dangerous manner. It would create chaos and uncertainty, new levels of marketplace instability, higher premiums and out-of-pocket costs for many, and an increased instability throughout our system. Sorry, notes are a little off. It would also, and probably most significantly, take away the financial resources and the certainty about those resources that are critical for states to maintain coverage and to continue moving forward. As the group of 10 governors, both Republicans and Democrats, wrote earlier this month, Graham Cassidy is not the answer. Instead, we need bipartisan efforts to make health care more available and affordable for all people, including America's taxpayers. My remarks will look at the key implications of this proposal on Medicaid and the 73 million people covered by that program, focusing on 3 points. First, it's important to keep in mind that the Graham Cassidy proposal builds on the Better Care and Reconciliation Act, BCRA, the bill that was voted down by the Senate in July. BCRA imposed deep cuts to the Medicaid program, and so does Graham Cassidy. CBO estimated that BCRA would have cut Medicaid by $756 billion over 10 years, and those cuts grow over time because the per capita cap included in both proposals gets tighter in the out years. The cuts in BCRA to Medicaid come principally from changes to the Medicaid expansion funding and to the caps on the federal funding for the program. The Graham Cassidy proposal maintains and deepens the cuts to Medicaid expansion that were in the BCRA bill. Not only would states no longer get the enhanced funding that is provided under the ACA, but under the Graham Cassidy proposal, states wouldn't even get funding at regular match rates to be able to cover very low-income adults. And Graham Cassidy, like BCRA, would impose arbitrary caps on federal funding for virtually every population covered under traditional Medicaid. That means the federal government would end its commitment to share the full cost of providing coverage for pregnant women. For children, Medicaid covers 1 out of 3 children in this country, and for people with disabilities and for the elderly. 6 out of 10 of the dollars spent in the Medicaid program is for people over 65 and people with disabilities. If Congress adopts the Graham Cassidy proposal, it is cutting and capping funding for the very beneficiaries whom the supporters of this legislation point to as those who Medicaid ought to protect. My second focus is on the block grant that Graham Cassidy creates in place of the Medicaid expansion dollars and the tax subsidies and cost-sharing reductions. Let's start with basics. First, it is a block grant, which means the dollars do not grow based on actual cost of care or based on enrollment. Overall, at least looking at the version of the bill that was released on September 13th, the block grant cuts about $82 billion between 2020 and 2026. But if healthcare costs are higher than projected, the need for coverage or subsidies is greater than anticipated, the gap between actual need and funding widens. The second basic fact is that the funding for this block grant, has been pointed out, is time limited. But let's go beyond the basics. Graham Cassidy reshuffles the deck, allocating dollars not based on historic spending or projected need or costs, but to the point where every state gets the same level of funding per poor person. You could say it creates a one-size-fits-all funding formula. The problem is, one-size-fits-all makes little sense. Our analysis in a report attached to my testimony is similar directionally to other analyses. 29 states would receive less federal funding than they would under current law, with an average reduction of 19%. In 2026, 18 states plus the District of Columbia would lose 1/4 to one, or more of their funding, including 6 states represented on this committee: Delaware, Colorado, Michigan, New Jersey, Oregon, and Washington. 6 states, including Alaska and Oregon, would see their funding cut by half or more. There would be adjustments, but in some cases, whether those adjustments are made, and in all cases, how those adjustments would be made, would be left to Secretary discretion. States don't know and won't know what those allocations will be, but most notably, those adjustments have to be budget neutral. Upward adjustment for one state means a downward adjustment for another state. The block grant does provide states with broad flexibility, except, of course, with respect to whether a state can continue to rely on Planned Parenthood clinics to provide women health care services. But how many of us really believe that a state that loses 1/4 to 1/2 of their funding will be able to replace the lost coverage and to improve stability and costs in the marketplace? That kind of flexibility only means that states will be able to decide which groups of people won't get coverage, which services won't be covered, and how many people will see their premiums and out-of-pocket costs go up rather than down. Finally, I just want to touch briefly on the issue of implementation. Simply stated, Graham Cassidy would create chaos in our healthcare system with frightening implications. 23 million people are projected to receive coverage through the marketplace and the Medicaid expansion in 2019. On January 1, 2020, by the terms of this proposal, that coverage and those subsidies will end. It is simply impossible for states to make their plans and have new programs in place by then, even without even considering that they won't know how much money that they have from year to year, or whether they will have any money in 2027. On this point, let me quote Dr. Atul Gawande, who wrote that with respect to implementation, it's not just impossible, it's delusional. There are no winners in this bill, but there are many who will lose and many others who will be at grave risk. It's instructive to consider the array of special fixes in this bill. There are many, and they are growing with every version, all aimed at softening the blow for one state or another. Whatever else you might think about these special deals for certain states, they do help us appreciate just how flawed the underlying structure of this bill really is. Thank you for your time.
Mr. Woodruff will take your testimony.
Thank you, Chairman Hatch and Senator Wyden, members of the Finance Committee. I appreciate the opportunity to speak about the needs of cancer patients today and other patients with serious and chronic illness. But first, I want to say this, as you said, this committee has a long tradition of bipartisan achievement and workmanlike effort, and passing the CHIP bill many years ago, funding the tobacco tax with that was a twofer for cancer, and I'm honored to be here before you today. Let me start with a short personal story. I'm sure everyone in this room has one, given that 1 in 2 men and 1 in 3 women are diagnosed with cancer in their lifetime. My mother was diagnosed at the age of 48 with breast cancer. In 1963, the standard treatment was a radical mastectomy and massive radiation. She survived and lived to be 93, which was a wonderful thing, but she was lucky. For 45 years thereafter, she lived with a pre-existing condition. My dad had a good job with insurance that kept her covered until she reached Medicare, so she was lucky again. My point is, until 2010, cancer patients and survivors had to be lucky to get coverage and access to care. Those who had to buy in the individual market were mostly priced out of it. Others faced annual and lifetime limits on their benefits, and as a consequence, many families with cancer faced medical bankruptcy. That all changed with passage of the Affordable Care Act. Patients had certainty and stability, They could buy insurance that covered their care no matter their health status. Very low-income working single men and women for the first time had access to coverage through the Medicaid expansion. Yes, the current system has flaws. Premiums are far too high for some families. And 19 states declined to expand Medicaid, which has left over 4 million low-income citizens uncovered. That Medicaid patchwork created by the 2012 Supreme Court decision is revealing of what could happen if the Graham Cassidy bill is passed, creating a new patchwork of standards in 50 states in both Medicaid and the individual market. The bill before you would completely restructure the individual markets in Medicaid, as others have said around the table here. And how that would come out in each state is not known. What is known is that the proposed cuts to Medicaid delivered through the block grants of per capita caps will end Medicaid coverage for millions of working men and women and children and disabled citizens. The mandatory patient protections in current law that explicitly prohibit pricing based on health status, the essential health benefits, and the ban on lifetime and annual caps that are tied to those benefits, all of those would become discretionary, depending on what state you live in. And now some states could decide not to cover even preventive services, like cancer screenings, routine mammography, or colonoscopy. Prevention is the key, really, to cancer, to treating cancer, and it's really a way to have health care much more expensively if we encourage prevention. A couple of weeks ago, I was struck by the common sense statement that was made by former Governor and HHS Secretary Mike Leavitt during his testimony before the Health Committee. When he was asked about the appropriate balance between federal and state involvement in health care, he said we need to have national standards and state solutions, because without a national standard that ensures adequate and affordable coverage, how do we really make sure that people get the treatment they need when they get sick? As others have said, the timeline written into Graham Cassidy for each state to restructure Medicaid and redevelop their individual markets by 2020 is not realistic and not likely feasible. In the words of the state Medicaid directors, states will need to develop overall strategies, invest in infrastructure and systems changes, negotiate provider and managed care contracting, et cetera, et cetera, et cetera. This is not a group, this group that said that is not a group with a reputation for hyperbole. We are worried at the Cancer Society for millions of people that may lose their insurance. Hundreds of billions will be taken out of health care if this bill passes. If the EHB goes away, so does the protection against annual and lifetime caps, because the caps are tied to those benefits. Insurers could be allowed to offer plans that don't cover treatment or all of the services that cancer patients need. In that situation, the plan they need may not even be offered, or it may be too expensive for them to afford. And then they go without coverage. And this is what happens. Their cancers are discovered later, they're more expensive to treat, they have a lower chance of survival, their medical costs force them into debt, they forgo preventive care and cancer screenings, and we're right back to where we were 7 years ago. With health care, what people want is stability and certainty. Our goal is to relieve patients of their fear. Cancer is scary enough, but what's really frightening is not being able to afford to fight it. American Cancer Society, Cancer Action Network, and our affiliate, the American Cancer Society, are nonpartisan organizations, and we believe the only way to resolve this long impasse over health care coverage is a bipartisan solution. We'd like to work with the Finance Committee going forward and help you find solutions that improve the current health care law, ones that make premiums affordable for all Americans who need health care. Thank you again for the opportunity.
Well, thank you, sir. We're grateful for this panel. It's been an excellent panel, and let me just start the questioning by asking you, Senator Cassidy, can you please walk us through the changes made to the text that posted on your website this morning so we all have a clear understanding of the current language?
Yeah, so what we found as we introduced our first bill is that the rate of inflation was far higher for the individual market and Medicaid markets than we had anticipated. And that rate of inflation did cause a transfer of dollars from those states which had expanded to those which had not. We want equity so that no matter where an American lives, she or he can get the care they need, but we also didn't want to see an abrupt change. So we did a couple things to, frankly, at the expense of the non-expansion states. We prolonged the glide path to equity. So now equity only occurs out in 10 years, not in 6. Secondly, we capped the amount of money a state could see as an increase to 25%. So Mississippi, for example, that ends up going up dramatically because they're so low now, is capped at 25% per year. They do really well. The folks in Mississippi will have far more resources to screen and treat for cancer than they do now. But nonetheless, it prevents a dramatic shift for other states. And so in that way, secondly, we went around and we looked at some states. They were just outliers for whatever reason. Hawaii and Alaska have federal poverty levels that are 1.5 times that of the other 48. But they only get paid by Medicaid as if they were the same as the other 48. So we actually, for those two states, we corrected the amount they get from Medicaid so that Hawaiians and Alaskans will have a more appropriate reimbursement for the cost in their state. We did other things like that, trying to minimize, whether it was a blue state or a red state, a problem they may have with this new formula.
Let me ask you this, Mr. Smith. How can the federal government work with states to promote private market coverage for low-income individuals while preserving Medicaid for the most vulnerable?
I think, Mr. Chairman, states are already experimenting with those strategies now, including Arkansas, in which our Arkansas elected to have the Medicaid expansion under the previous administration. We have continued to refine that and develop it, but the reality is the public-private partnerships that we have been finding in Medicaid for the last 20 years, in which private sector managed care companies are now delivering a great deal of the services to the Medicaid population. In Arkansas, the private qualified health plans marketed on the exchange, 80% of the subsidies, the amount of subsidies, are for a Medicaid-eligible population. So, again, I think that where we are in these private-public partnerships, they've been underway for 20 years. There is a platform to build upon.
Thank you, Senator Wyden.
Thank you very much, Mr. Chairman. Mr. Chairman, first of all, when this hearing was announced, we set up on our side a website so we could hear from the American people. Almost 27,000 citizens commented. I would ask, per our agreement, unanimous consent, that all emails sent to our site by the start of this hearing be entered into the record.
Without objection.
Thank you, Mr. Chairman. First of all, before I get into my questions, I want to make 2 points that I think my colleagues are going to echo. First of all, we feel very strongly on our side we ought to be working on a bipartisan basis today. There are 2 clear opportunities for the Senate to do that. The first is our bipartisan CHIP bill, where funding is going to run out at the end of the week. And the second is working to stabilize the private insurance markets. That is what we are for on this side of the aisle. And finally, we think this process has just been an abomination. We're talking about something that is going to affect millions of Americans. We don't have any objective information about what it's going to mean to people's premiums. We don't know what it's going to mean with respect to coverage. We don't know whether the health markets are going to survive in the next year. We ought to have that information. That's what you get if you take the time in the regular order. Now, Senator Cassidy, let me start with you. You managed to bring together people and organizations in the healthcare field who rarely agree. I guess congratulations are in order because they all think what you're talking about is a disaster. And they particularly agree that America's healthcare system is going back into the business of charging folks with pre-existing conditions more for health insurance. Now, I would like a yes or no answer to this question. The question is, do you continue to believe that the thousands of doctors and hospitals and patients groups who are writing us saying that you're wrong on pre-existing conditions, do you continue to believe as of today they are wrong, and that is a yes or no answer?
That is begging the answer. I think if you're in an orange state in which you did not expand Medicaid, so therefore the patients and hospitals in your state do not get benefits. If you are in Maine or Missouri or Florida or Virginia, you are pleased about this bill.
I asked you a
And so the
yes
simple
or
answer-
no answer.
But you're
I asked
begging
you a
the
yes or
answer,
no
and I
question.
think it's more important to have the right answer than the one that is begged. And I don't mean to be disrespectful, but if you're in, the Tennessee governor said this is a gold mine for, or a godsend or something like that for Tennessee. If you're a doctor or a hospital in Tennessee or Missouri or Maine, you're so pleased about it. Now, if it's a
Mr.
national
Chairman,
association.
let the record show that our colleague does not want to answer the question, and it appears to me that the revised bill, the one we got this morning, indicates that a state could allow insurers to set higher premiums based on a person's health status. Now, what I'd like
That
to
is
do...
not true, by the way.
Well, let me,
You're entitled to your opinion. You aren't entitled...
Senator, let me just interrupt for a minute, and I'll give you the extra time. Look, I want our colleagues treated with great respect. It's not easy for him to testify on this, although it is, because he's a doctor. He understands this probably better than anybody in this room, or at least any of us. Although I was a medical liability defense lawyer, so I'm not some neophyte here. And I've probably passed more health care bills than anybody certainly in the Senate. So let's show some respect for Senator Cassidy. This is not easy for him. The fact that you disagree with him, that's fine. But he ought to be able to disagree with you also. But go ahead. We'll give you
Mr.
the
Chairman,
extra time.
one of our past great chairmen, Pat Moynihan, said everybody's entitled to his own opinion, but not his own facts. So let's hear from the American Cancer Society with respect to the real facts. They've got a lot of members who understand the hurt that comes from being discriminated against for having a pre-existing condition. Mr. Woodruff, what do you think with respect to this bill and what it's going to do to people with a cancer fight on their hands?
Well, it doesn't protect them, Senator. It basically makes the patient protections that were enacted into law in the Affordable Care Act discretionary on the part of each state. And each state can decide to keep those patient protections or not. But what's important about what the Act achieved was it created a definition, a national standard for what is adequate in insurance and what is affordable. And so with the essential health benefits, we actually have an assurance that when you buy insurance, it's going to cover the services that you need when you're sick, whether you have cancer or any other disease. The essential health benefits are there to protect you.
Thank you.
Sure.
And I want the American people to understand the consequence of that statement. The Cancer Society knows something about what it means for patients to get clobbered by an extraordinary illness. And what they've said is this opens up the door to charging those people more. Now, let me ask one other question, if I might, Senator Cassidy. We are trying to make sense out of all the bills that have been released. So here's the first bill. This was posted on your website on September 13th. This is the second bill that was on Senator Graham's website. That was on September 13th. We got a third version last night at 7:30, and we got a fourth version last night at 7:50, and then we got a fifth version at 9:23 in the morning. Now, is this bill the one that the United States Senate is going to actually be voting on? Because I think the American people would like to know. We are on the cusp, we are on the eve of voting on this extraordinary piece of legislation. We're trying to sort out what it is people are even going to vote on, let alone the fact we don't know what's going to happen to their premiums. We don't know what's going to happen to their coverage. We don't know what's going to happen to individual markets. Is this what we will actually be voting on?
A couple things. Senator Wyden.
That's a yes or no answer, colleague.
Can I say something, please?
Of course.
I apologize earlier if I was rude to you, and I'm sorry I did not intend to be. The last version was correcting drafting areas. 99.9% the same, it just corrected drafting errors. And lastly, I'll say it's 148 pages, not 990 pages, as was the Affordable Care Act. So the American people should be able to read this and comprehend it.
So is this the last version?
Yeah, I believe so. I mean, there might be a drafting error. I hope correction of a drafting error does not constitute a whole nother version. It's just like a drafting error.
All right. Again, I want to highlight, colleagues, we have one of our colleagues, and I want to treat every member of the Senate with the opportunity to be heard. We got this at 9:20. I just don't think when you're talking about a bill of this magnitude and our colleague saying he believes that this is the final version, that that's good enough when we're talking about putting at risk millions of Americans. Thank you, Mr. Chairman.
Thank you, Senator. Senator Grassley.
First of all, for the people that introduced this bill, I want to thank you for your leadership, truly improving the American healthcare system. The point's been made. I think Senator Wyden made a point about all the stakeholders that are involved in this bill and against it. They have concerns about it. I think that those of us in Washington know that when all those strong forces speak up, it's to protect the status quo or protect our interests. It really isn't about providing adequate health care for Americans. What I care about is what happens to Iowans. Obamacare has failed in Iowa. There are only one company planning to offer insurance in 2018 in Iowa. That company's premiums are well over a 50% increase. People in Iowa tell me their copays and deductibles of Obamacare make it too expensive to use. These are issues that must be addressed. Today, despite our ideological differences, we're able to have a discussion about a path forward. Dr. Kennedy, if I could have your attention, does this bill spend more dollars in 2026 in Iowa than it does today in Medicaid, subsidies, and reinsurance?
It does.
Well, obviously it's not a cut then. Isn't this slowing the rate of growth?
It does slow the rate of growth across the country. It does.
Doesn't everyone agree we need to slow the rate of growth in healthcare spending?
Apparently not everyone, but I would.
Okay.
And by the way, I can also say that I have words from Senator Wyden when he previously introduced a Medicare bill in which he said a cap on growth serves as a backstop. And the best way to hold down health care costs is give Americans the ability to hire and fire their insurance company. So I think that these caps on growth has been something in the past which has had bipartisan support.
To you also, do states have the right incentives under the current Medicaid program, matching fund system to control costs by coordinating care and fighting fraud?
You can empirically say they do not, that it's a cost-plus program. The more the state spends, the more they get. The only limit is on the ability of the state fisc to support their end of the match.
Lobbyists for the American Hospital Association, the American Medical Association, the AARP, and the insurance companies all endorsed Obamacare. Could you say that these folks have a financial interest that does not take into account individuals in Iowa?
If you look at the stock prices of insurance companies, pharmaceutical companies, and for-profit hospitals, since Obamacare passed, they've done extremely well. In parallel, premiums have risen for those who do not get subsidies, and tax outlays have risen for the American citizen. There's a direct relationship between the two. They've done extremely well under the Affordable Care Act.
Okay, I've got time left for 3 questions, so I hope I can have short answers. I want to ask Mr. Smith, is Medicaid sustainable at its current inflation rate?
Whether you look at the Government Accountability Office or the National Association of State Budget Officers, the answer would be no.
Ms. Mann, is Medicaid sustainable at its current inflation rates?
States are working very hard right now and have been to be able to improve their programs through better delivery of care and different payment mechanisms that reward value rather than volume. Taking away the foundation of coverage will only make costs grow because people only come in when care is needed and more expensive. So we need to control the rate of growth, Senator, but we need to do that in a way that improves care rather than takes care away.
The same question to you, Ms. Miller. Is Medicaid sustainable at its current inflation rates?
Thank you, Senator. I would echo Ms. Mann's comments and also say I think this whole debate for the last several years has been about coverage, and we haven't been talking about the cost of health care. At the end of the day, insurance is a reflection of the cost of health care. So if we don't have a debate in this country and a discussion about how we get at the underlying cost of care, we have a major problem. That's really the debate we should be having and the discussion we should be having.
Okay.
Mr. Chairman, you want Senator Stabenow next? Yeah. and
Well, thank you very much, Mr. Chairman. So much to talk about, I'm not sure where to begin, and I did want to talk about specific provisions and thank all of you for being here, but I do feel like I need to talk numbers, even though this has got to be about people, not numbers. Let me just say the truth of the matter is when we cut down the number of people walking in emergency rooms that don't have insurance, which is what's happened in Michigan. We have 50% fewer people walking in the emergency room that can't pay. State of Michigan's saving money. Our Republican governor, working with Democrats and Republicans in the legislature, did the right thing, made sure that people who are minimum wage workers could receive health care and take their children to the doctor. And what's happened? We've saved $435 million in taxpayer money because people can go to the doctor instead of using the most expensive way to get health care, which is the emergency room. Let me also just say that it just came across the news that Standard & Poor's has now said that this bill would cost 580,000 jobs in 2027, 580,000 jobs. So that's something we certainly want to look into. I think I want to take just a moment to go to this whole question of whether or not this, as Senator Santorum said, is a modest change, and welcome back to the committee, a modest change, or as Ms. Miller said, a staggering cut, because that's a pretty big difference. And Senator Cassidy has indicated that, well, it's a block grant. Cassidy is a block grant, and after 10 years, we can just continue it like we do other block grants. Well, here's the reality. In 10 years, in order to continue that block grant, would cost $190 billion for that next year at level funding. The entire Health and Human Services budget for our country is $164 billion. So if we stop doing everything else in education and health and human services, you couldn't pay for extending that block grant. It's not believable. It's just not credible. And I want to show one other thing. These are the staggering numbers for me in Michigan, because the cuts to Michigan, when this is fully implemented, according to Avalier, is $140 billion. $140 billion. Our governor just signed next year's budget, $56 billion. There's no way, there is no way that we will not see people's health care, nursing home care, children's health care cut as a result of this bill. Let me get into specifics, and let me talk about something near and dear to my heart, and that is under essential benefits, we have said that maternity care would be covered. And as a result of that, and I do have to say that maternity care was a major debate in this committee as one of the 10 essential health benefits, trying to make sure that just being a woman wouldn't be viewed as a pre-existing condition or somehow women having to pay more for a rider if a young family wants to have a child. Interestingly, my staff tells me it was 8 years ago today in this committee when a former colleague from Arizona and I had a debate back and forth about whether or not we should cover maternity care. He said he didn't need it, shouldn't be covered. I reminded him that his mom probably did. And so we ended up putting it in. And so now here we are. We have a situation where we could very easily be going back to pre-health reform days, when in Michigan, only 4% of the plans that a young couple could get on the individual market would cover maternity care. And we know from studies that young couples get married and may not be planning on having a child for a long time, and then whoops, more than half the time, there's an unplanned pregnancy. And so then she has a pre-existing condition. And prior to the Affordable Care Act, couldn't find any care. We also know that if to get an average coverage rider at that time was over $17,000. And if you couldn't find coverage, you'd be paying from $30,000 up to $50,000 out of pocket. And so, Ms. Miller, I wonder if you might respond to the issue of maternity care and your experience as an insurance commissioner. Can you talk about what the individual market looked like for women a few years ago before maternity coverage was a basic benefit?
Thank you, Senator. And I think my experience is similar to what you just indicated. I think women before the ACA, if they had coverage in the individual market, often did not have an option to purchase coverage that included maternity as a benefit. We have a lot of discussions about what should be in the essential health benefits package, and this bill obviously gives states a lot of latitude to waive those essential health benefits. But where I struggle is when you start looking at those essential health benefits, I don't know which one is not truly essential. And maternity coverage is certainly one of those benefits that in my mind is absolutely essential. And I worry that if we go back to the world that we had before the ACA, where women in the individual market couldn't get coverage to cover maternity care, then they're left paying out of pocket tens of thousands of dollars if they have a baby. And I think then we return to a world where we see people going bankrupt because they simply can't pay for the medical bills that they have.
Thank you very much. Thank you, Mr. Chairman.
The acting presiding chairman recognizes Senator Roberts. Thank you, Mr. Chairman. Fact, the Affordable Health Care Act is
I
not...
object. Just kidding. That was a joke. Thank you, Mr. Chairman.
Would the timer please not count the gentleman from Colorado's, the senator from Colorado's untimely insertion of his remarks? This is about much more than trying to fulfill campaign promises, I think. Simply put, the Affordable Health Care Act is not affordable. It's failing the people, the very people that promised to help. Insurers continue to pull out, limit coverage in states. They are requesting dramatic premium increases again for next year. In Kansas, premiums have doubled since the law have been in effect. Next year, if we assume all the plans that have filed rates in the state sign that final contract in the next few days, all Kansans will have just two options of insurance carriers on the exchange, and one is on a teeter-totter. They may also face premium increases of up to 29%. When I was back home at the State Fair in Hutchinson, Kansas, just a couple of weeks ago, there was nothing but concern and frustration and, yes, anger from my constituents over the law's failures and questions, if not demands, as to why we here in the Senate have not successfully passed reform. Now, I do believe, as has been pointed out, that we reached bipartisan agreement that the law is not working. Over in the Health Committee, it's been pointed out. We've held numerous hearings over the past several weeks to review proposals to address premiums instability in the individual market next year. Unfortunately, many of our colleagues simply wanted more money to patch this problem, not proposals to address many of the law's fatal flaws. There is another alternative out there. Longtime champion of single payer, Senator Bernie Sanders, has recommended Medicare for all, government-run health care, and has reintroduced his proposal with 16 senators of my friends across the aisle endorsing that idea. I am continuing to review the proposal before us from Senators Graham and Cassidy and others, getting feedback from actuaries, the Congressional Budget Office, and most importantly, Kansans. What I am positive of is that this proposal that we have before us certainly is better than socialized medicine. Senator Cassidy, one provision that is included in your proposal and many of the other proposals Congress has considered over the last year to address the increasing growth in the Medicaid program. I'm being repetitive, but I think it needs to be repetitive, and that is switching from an open-end entitlement to what is known as per capita caps. Would you constitute such a reform proposal where spending continues to increase every year, as slashing the program?
No.
While its inclusion in the debate surrounding the Affordable Health Care Act has led many to believe this is a Republican-only idea, it is not. It was actually something proposed by former President Clinton, embraced by former Chairman Baucus of this committee, then Senator Biden, and Senator Patty Murray. Our Kansas Medicaid folks tell me they estimate Medicaid spending in our state to increase 3% a year over the next few years. Senator Cassidy, what is the growth rate in your proposal for my state?
There's two aspects to your state. In the traditional block grant, if you will, you're going to Kansans will have lots of money for cancer screening, et cetera. In Kansas, you'll go from receiving $2.9 billion from 2020 to 2026 under current law. Under our proposal, you would get $4.7 billion from 2020 to 2026 to provide cancer screening and cancer treatment for lower-income Kansans.
Is it fair to say the Kansas cap is in fact higher than what they currently spend?
Yes, you can spend, you can also supplement, if you will, the traditional Medicaid budget with the extra dollars that Kansas is receiving, and you have the flexibility to do that as well.
Let's go to the yes or no questions, but you can cheat on that a little bit. Are dependents up to 26 still allowed to remain on their parents' plans?
Yep.
Will mental health parity requirements still be in place?
Correct.
Let's say a state does submit a waiver to redefine the essential health benefits. That's been a concern. Got to get the glasses up. Sorry to Ms. Miller and to Ms. Mann. Would prior state mandated benefits still be in effect, or are we looking at a Wild West, something like some are claiming?
No, states, there's the supposition that governors are not going to take care of the people in their state, which kind of underlies all these questions by some who oppose the bill. I disagree. I think governors want to take care of the folks in their state. But if they apply for a waiver, the statute specifically says that the governor must establish that those with pre-existing conditions have access to, quote, adequate and affordable coverage. If they fail that, there's a provision in which the Secretary of HHS can pull dollars back, both deny and pull dollars back if they misuse the funds by not providing access to adequate and affordable coverage.
Senator Carper.
Thanks very much. Welcome to all of our witnesses. Thank you so much for your testimony, your presence today. I have a friend, you ask him how he's doing, he likes to say, compared to what? And I'd like for us to go back about, 8 years or so ago, the time that we spent in this room debating the Affordable Care Act. We did not have 1 day of hearings. We had, as I recall, 97 hearings, roundtables, and walkthroughs on health care reform, 97. The Senate Finance Committee itself did 8 days of markup on the legislation. I think 130 amendments were considered. We actually had the folks who run CBO here at this table to tell us what the effect would be on our budget if the Affordable Care Act were adopted. And we're told that under their score, which they actually had time to produce, the budget deficit would be reduced in the first 10 years by $130 billion, in the second 10 years by $1 trillion. During the course of the debate here in this committee, in the Health, Education, Labor, Pension Committee, some 300 amendments were offered, 160 Republican amendments adopted. The Senate then spent 25 consecutive days in session on health care reform, second longest in the history of our country. We're here for 1 day of a hearing, 1 day. You asked my friend how he's doing. He says, compared to what? Well, how about compared to what you participated in, Ms. Miller, in the last several weeks before the Health, Education, Labor, Pension Committee? They didn't just have 1 hearing. Senator Alexander and Senator Murray had 4 days of hearings. Governors, insurance committees, providers, health insurance companies, health economies from all over the country. 4 days. And those were preceded each day by roundtables, bipartisan roundtables where people like us who don't serve on the Health Committee could actually meet with and question the witnesses, including you. That's what we did. This is an unprecedented effort. I mean, we've gotten, one of the things that I take my hat off, and I think our 2 Republican colleagues, one currently here and one who used to be here with whom I worked on welfare reform, bipartisan effort. I look for a panel of witnesses to be able to unite us. And I would say this proposal from my friends have united some 400 organizations, healthcare organizations, and groups across. I've never seen a coalition like this in my life. Maybe they're all wrong. Maybe they are all wrong. They stretch from coast to coast, every nook and cranny, but they say, please don't do this. Slow down. Hit the pause button. And do what Ms. Miller has suggested over and over again, and what our colleague John McCain suggested again as recently as last week. One of the things that's missing here is Obamacare. Where did it come from? It came from, really, initially from the Heritage Foundation. They were asked to develop a market-based alternative to Hillary Care, and they did. It was introduced in the United States Senate as legislation by John Chafee, Republican from Rhode Island, co-sponsored by two of our colleagues here, the senior two Republicans on this committee, Orrin Hatch, Chuck Grassley co-sponsored that legislation. It's called Obamacare. Barack Obama had nothing to do with its creation. This is a Republican invention. And frankly, as one Democrat, I thought it was a pretty good invention. It's kind of like Dr. Frankenstein operating on his patient, trying to kill it. Well, why don't we fix it? And let me say, Ms. Miller, during these debates and the hearings that you participated in, what were some of the good ideas to fix that which the Republicans initially created and now call Obamacare? What are some of the cures?
Thank you, Senator. I think what we heard from commissioners from red states and blue states is, the problems with Obamacare are really just in the individual market, and most of the people in that market have access to financial assistance, so the law is actually working well for them. It's really for the people that aren't getting financial assistance that it's not working well for. But I think what you heard from all of us, whether we're from a red or blue state, is that continuing to pay cost-sharing reductions, CSRs, implementing a reinsurance program, ensuring that we have an effective mandate in place, making sure we get more young, healthy people into the pool, and then importantly for our whole system, trying to figure out how we can get at the underlying costs of care and try to reduce those. Those are things I think we could all get behind, and there is a path to a bipartisan solution here to fix the individual market, which is really where the problems are. If we all come together, I know we could get there, and I think we outlined that in the Help Committee.
Yeah. Colleagues, I was in Boston. I was in Boston last Friday. And I talked to a number of people there about Romney Care, which is really based on the heritage ideas. And I said, how are you guys doing with Romney Care up here? He said that 98% of our people are covered. The increase in our premiums for the last year, 4%. And one of the reasons why is because they have a healthy mix of people to be insured, and they have a lot of competition within the exchanges. That's what we need to do, and we got to fix this. The idea of simply doing this, legislation that's before us today, and not stabilizing the exchanges, which are eminently stabilizable, eminently so, is a big mistake. Thank you.
Thank the senator, the distinguished senator from Ohio, Senator Portman.
Thank you, Mr. Chairman, and to my colleague, Mr. Carper. Nobody is more focused on a bipartisan solution than you. I get that. I will say that the experiment in Massachusetts was what they wanted to do, and with a lot of flexibility, they were able to put together a plan that works for them. Their costs are also very, very high. Their health care costs are probably some of the highest in the country. But that's how they chose to do it. And I think what has been missing a little bit in this debate is, what this is all about. And it's a very different proposal than the proposals that we have been looking at previously. This is one reason that Senator Graham and Senator Cassidy have received some heat from conservatives, because it takes the funding in the Affordable Care Act and it sends it back to the states. And gives the states the flexibility to be able to do what they think is right for their citizens, and to be able to more effectively cover low-income citizens in those states. I totally agree with what Ms. Miller and Ms. Mann, Democratic witnesses this morning, have said in terms of getting at the underlying costs of health care. I would just suggest that one way you're going to get at the underlying costs of health care is to give the states that flexibility to be able to get at it. And we seem to be sort of talking past each other a little bit, but that's fundamentally what this is about. Yes, there is a change in traditional Medicaid as well, and we can argue about that. I mean, as Senator Graham said earlier, if you don't do something on Medicare and Medicaid, it takes up the entire budget within, 30 years. I mean, everybody, I think, acknowledges we got to do something on entitlements, I hope. If not, we've got to figure out an entirely different way to get revenue in this country. But even there, again, there's been some criticism from the right saying, this is essentially taking the existing costs and continuing them. I mean, if you look at the per capita, that means that it increases by population, so the Medicaid, traditional Medicaid does change, but it goes up by population. But second, there's an annual adjustment by inflation, and it's at medical inflation and medical inflation plus one. What CBO projects for the rate of growth with regard to, for instance, blind and disabled category under Medicaid is actually slightly less than what these guys are proposing for their per capita program and the annual increase in Medicaid in that category, because it's M and M plus 1, 3.7%. So it is actually a proposal that's been a little bit mischaracterized. But let me just talk about why we're here then. I mean, what's the problem? And you all hear it because you all have individuals in your states who depend on the individual market, small businesses, families. I get a email from a guy named Dean. He's a guy who's lost his job back in 2009. He finally found a plan that worked for him. The Affordable Care Act comes in, he loses his plan. He's now paying, according to Dean, twice as much for a plan that has less benefits for him and higher deductibles. Mike from Westlake tells me recently our health care insurance rate, single employees, under 30 went from $198 a month to $560 per month. We just had a small business roundtable on Friday in Ohio. Healthcare costs was obviously a huge topic for them. And no wonder. Joanne from Dublin sends an email saying she feels she doesn't have health care at all because under the Affordable Care Act, her deductible's gone up to $11,000 for a family. We'll never reach that deductible. She says, I don't have health care. So here are the numbers from Ohio. And I don't know what your states are like, but we just, a couple weeks ago, published the numbers for 2018. 34% increase. Who can afford that? To these small businesses, what's our answer? And so the status quo is not working. And by the way, I agree with what Senator Carper said about the CSRs, these cost-saving reforms to be put in place to help with stabilization. If we do that in Ohio, the insurance companies say it'll be a 23% increase. So it helps, but it's still totally unacceptable. So I guess to you, Mr. Smith, because you're one of these experts who are dealing with this every day, can you explain how this block grant model would help someone I talked about, like Mike or Joan or other folks in Ohio who are seeing their costs just skyrocket under the Affordable Care Act?
Yes, thank you, Senator. Again, I think that giving the flexibility back to the states, I think we ought to judge what states will do on what they have actually done. And I would point out CHIP being a very good expression of that, where they had tremendous flexibility in defining what the benefit package was, defining cost sharing, et cetera. And states put their efforts into competition, in good comprehensive health care, and also trying to be as efficient as possible with those. Again, I think that, as I pointed out, the CBO got the insurance pool so vastly wrong because of the subsidized pool turned out to be much smaller and the Medicaid pool turned out to be much larger. This proposal puts those pools together, and bringing those healthy lives into a larger pool is what is going to help stabilize premiums.
Okay, Mr. Chairman, my time has expired. I look forward to a second round of questions. I'm going to talk more about the formula. So we talked about the theory of getting back. I do continue to have concerns, as you know, Dr. Cassidy, on the formula, and I want to talk to you more about that and how it affects the various states. Thank you, Mr. Chairman.
Thank you, Senator. Thank you, Senator. Senator Cardin.
Thank you, Mr. Chairman. I want to thank all of our witnesses for being here today. I ask consent that I can put into the record, Mr. Chairman, letters that I've received from people in Maryland in opposition to this bill and groups without objection so ordered. I want to point out that the process being used here today. I want just make it clear. We are 8 months past the time Congress, Senate passed the budget that we are now reconciling to with this amendment. We are finished the debate time on the floor of the United States Senate. We have had no committee markups, no chance for amendments. We don't have a CBO score on Senator Cassidy's proposal. We do know, though, that tens of millions of people will lose their coverage, premiums will go up, and the quality of coverage will go down. We do know that. So, Mrs. Miller, I want to concentrate on comments that have been made here. Senator Cassidy, I think, correctly identified the problem. We have a problem in the individual marketplace with individuals who are not receiving subsidies. And that's all the examples that Senator Portman just gave fall into that category. Now, in my state, I believe that's about 1% of the population. Now, that's a significant number. I'm not trying to underestimate the problem, but could you just confirm whether the numbers I'm talking about are correct?
Yes, Senator. In Pennsylvania, we estimate that that population is between 1% to 2% of the population. So, as you said, very small, very important, because they're buying coverage on their own, but very small.
So the proposal that is being brought forward, though, will affect tens of millions of people, because tens of millions of people are going to lose their coverage. Many others are going to lose the quality of their coverage. And we're going to see significant cost shifting for those who don't have health coverage. Mr. Smith, I think, correctly analyzed what the states are going to have to do. And I'm going to use his language. He says they'll manage to the cap. And I think that's accurate. States have budgets. They have to comply with their budgets. States have already shown great initiative in delivery system models to try to bring down cost and make the system as cost-effective as possible. So what is left to manage to the cap, seems to me, are two major factors. Reducing eligibility, cutting people off the Medicaid rolls, and then since they no longer have the mandate on essential health benefits, it's going to eliminate certain benefits that are currently covered. Is there other options available that I don't see?
Is that to me?
No, just Mrs. Miller.
Oh, okay.
When you're trying to cut the dollars out of a program like we would be doing, you really only have three levers. You can reduce the number of people receiving services, you can reduce the services that you're providing, or you can reduce payments to providers. And that's really those are really your options.
So that's how you manage to the cap. So I just going to, one of the individuals in Maryland who I was with today, Peggy Roche, was talking about her daughter who has absence epilepsy. And she's very concerned. You gave some genetic examples of families that have children that are born with disabilities, and how they're going to be at risk because the state, in managing to the cap, may have to limit the amount of services they provide to these high-cost individuals. So we had today a New Jerseyan, Allison Chandre, who identifies philosophically with pro-life, whose child was born with a rare birth defect, heterotexy. There wasn't a dry eye in the room as she explained what she's going through. But she said she knew at least this nation would take care of her child, that she wouldn't have to go into bankruptcy, that she had a protection that was out there. Aren't we in danger of losing that protection that's out there, that we say every child, every person's entitled to make sure that the benefits available? Isn't that lost under this proposal?
I believe it is.
And I could go through those that are suffering from the opioid drug addictions. We know before the Affordable Care Act that the programs didn't cover those services. That's certainly at risk as the state manages to the cap. Would you agree with that?
That's true, and I think it was brought up that mental health parity stays in place, but mental health parity doesn't guarantee access to coverage. It requires parity if you have the coverage to begin with, but that would not be guaranteed going forward.
And as Senator Carper pointed out, this proposal doesn't even deal with that 1% problem, because there's nothing in this bill that shores up the individual marketplace to deal with the specific problems that those that are trying to repeal the Affordable Care Act, continue to monitor. These are real issues that we have to deal with. And yes, dealing with the cost sharing, dealing with reinsurance, dealing with the mandates, that will actually deal with the problem, not this bill. And what we put at risk, we all talk about our compassion for those who suffer from cancer. But we know that some of the treatments are pretty expensive. Managing to the cap is going to limit the opportunities of those, for young women who have breast cancer, the type of treatments that will be available to them. I think that's what, Mr. Woodruff, you're saying is at risk. Thank you, Mr. Chairman.
Senator, if I
Thank you,
may.
Mr. Chairman. If you haven't finished, go ahead.
Absolutely.
Okay. Senator Scott.
Thank you, Mr. Chairman. Thank you to the witnesses for being here today to discuss this very important issue. I've heard a lot today about stability and certainty in the marketplace. And in South Carolina, it's a very important issue. In 2014, we had 9 insurers in the individual market. And as we look at 2018, we'll only have 2 left in the market and only 1 in the exchange. On top of the lack of choice in the marketplace, the South Carolina individual market has seen a 27% rate increase in 2017. That does not sound affordable to me. A 27% rate increase in 2017. On top of that, we're looking at a 31% rate increase in 2018. These rate increases are coming right out of the paychecks of the average person in South Carolina. Furthermore, the instability in the marketplace is so severe that those who signed up in 2017, out of 100 folks that signed up in 2017, only 69 are still insured. In other words, the stability and the certainty that we hope for in the ACA, it's missing. It's not missing in the future, it's missing right now. 31% of South Carolinians who signed up at the beginning of the year simply can't afford to continue their coverage. That's just the exchange population. But beyond the exchange population, families, spoke with one in Summerville, South Carolina, Brant, whose family pays $31,000 for their insurance. And the A in the ACA stands for affordable. That's not affordable at all. And on top of that, we still have 136,000 South Carolinians trapped in the coverage gap that are ineligible for any insurance. So when my friends on the other side demonize any effort to take a look at anything other than the ACA, well, let's fix it. They miss the obvious point that for so many people today, the ACA isn't an option. And yet, my friends celebrate Romney Care. We're saying, why not pass those decisions to every state to make decisions? And if you look at all the polling information, one thing's clear. Residents and citizens throughout the entire country say that their local and state politicians have their confidence more than their federal politicians. This seems like a no-brainer. To give the money to the states to provide the very important opportunity to carve out strong, reliable, affordable health care options for their citizens that they see at the Piggly Wiggly, at the Walmart, at the grocery stores every single night. Mr. Smith, based on your experience and your expertise, please delve into the issue of state flexibility and how this could create lower premiums and allow more South Carolinians to stay on their plan.
Thank you very much, Senator. And again, I think that in many respects, the states are the ones who understand their own markets. There is no such thing as a national health insurance market. Health insurance markets are statewide, and even below that, they are local. The idea that CMS, and again, they're my former colleagues, and I've got the greatest respect for them, but to say that they can manage every single market across the United States, just, again, the examples that you have made show that that isn't very well done.
We call that hogwash in South Carolina.
So to give back to the states the flexibility that they have, to be able to make decisions to adopt new tools that are on the surface and in some states that are trying to lead the way of helping, again, to manage to the cap, we now have managed long-term services and supports models that we didn't have previously, that we are now partnering with the private sector to be able to manage the highest cost individuals that are out there in the fee-for-service world, or what we used to call fend for self, the highest cost people having no one to coordinate their care, having no one to help them.
Thank you. I know that I'm almost out of time here. So, well, I figured Senator Cardin went over by about 63 seconds. I would just do the same. Thank you.
Okay.
One last question for my colleague.
Seconds.
Thank you so much, sir. Senator Cassidy, to Senator Cardin's point, which has to do with opioids. Can you share with us, amplify a little bit, how the Graham Cassidy proposal would help those folks who are today suffering under the weight of opioids?
Mental health parity protections are maintained per the current law. That's number one. Number two, states have the ability to take this money and to craft something which is particular for the opioid epidemic. It doesn't have to fit into somebody in Washington, D.C.'s concept of what it should look like. It can fit into what that state knows works in the locality in which it is needed.
Thank
the
you.
state have the ability.
Thank you, sir. I wanted to answer that question for Senator Cardin.
Senator Bennett.
Thank you, Mr. Chairman. I'm not sure quite where to start. I can tell you this to my Republican colleagues, and I know they'll disagree with this. Edmund Burke is spinning in his grave at legislation like this. The kind of dislocation this is going to create merely to keep a campaign promise to repeal Obamacare is a disgrace. The senator was quite incorrect earlier when he said that we didn't have a bipartisan process in place. Ms. Miller has testified to that. At the Help Committee, we had a number of hearings, both in the committee room and outside, and I think, Ms. Miller, you said that there was actually a consensus between Republicans and Democrats. Isn't that correct?
That's correct.
And what we were trying to deal with in a conservative manner was to deal with the individual market, which these folks are talking about having been destabilized. That is to say, they have said it is destabilized. It is in many cases destabilized, and that is what we are trying to address. Isn't that correct?
That's right.
And that's 7% of the people that have insurance in this country.
Or less.
So, or less. And of those, the ones that have need of subsidies are even far less. Isn't that correct?
That's right.
And I would say that all of our politics for the last 9 or 10 years almost about health care has been distorted as a result of trying to figure out what the right answer for that 7% is. Would you agree with that?
Absolutely.
And now we're right at the moment where we have bipartisan consensus on how to deal with that 7%, and it's snatched away in favor of this partisan effort. Isn't that right?
That's right.
Or I'll say that. You don't need to agree with that. It is true. And the only, as sitting here listening to the comments, the only thing I can come to is to a conclusion that says this is to keep a campaign promise to repeal Obamacare, because in the bill we talked about in the Help Committee, Obamacare would not be repealed. Isn't that right?
That's right.
And we might have to admit that it wasn't actually a complete Bolshevik takeover of the United States economy. You don't have to answer that. And instead, well, let me ask you this, Ms. Miller. Is there anything in this bill that's responsive to the bipartisan testimony we heard in the Help Committee?
While there is a 2-year reinsurance program, I will tell you that is not going to be enough to stabilize the market.
Is there anything in your mind as an expert, somebody who's an insurance commissioner, is there any doubt in your mind that this bill will create massive instability in the private insurance market for the 7% of the people that are in that individual market?
There's no doubt in my mind that this will create chaos.
And you will own that chaos, because if you don't do what the consensus was with the CSR and with the creating some flexibility and the having the mandate or some other idea to have the mandate, you will get instability like you have not seen before, right?
That's right.
And so why are we here, colleagues, making matters worse? It is disgraceful. As all of you have said, and I will agree, there are things in the Affordable Care Act that need to be fixed. You know, and my view is this on that subject. Whether you're for the Affordable Care Act or you're not has a lot to do with whether you supported President Obama or not. Not exactly, because there are people that have, you know, had pre-existing conditions before who are now covered. But it tends to be that way. But what I discover in my state is whether people support the Affordable Care Act or whether they don't, they're deeply dissatisfied with the way their family intersects with the health care system in America, with the way their small businesses intersect with the healthcare system in America, because they know they're having to make choices that nobody else in the industrialized world have to make, because this Congress can't get its act together. And right now, when we have this issue staring right at us in the individual market, we choose not to take any of the recommendations that have been made in a bipartisan way in hearings in the Health Committee, and on top of that, we look for an excuse to cut poor people off of Medicaid. Do you think that about sums it up, Mr. Woodruff?
I think that sums it up very well.
But I ask you, do you work for an insurance company?
No.
Is the American Cancer Society an insurance company?
No.
So let me just close by saying I cannot believe the hypocrisy of people supporting this bill and saying that they're fighting against insurance companies when what they're doing is stripping hard-earned consumer protections from the American people. It is a disgrace. And what we should be doing is going upstairs to the Health Committee, continuing the bipartisan work that Ms. Miller described, and addressing what is a serious problem in South Carolina, in Ohio, and in Colorado. As somebody who voted for the Affordable Care Act, and I still have less time than Mr. Scott or Senator Cardin, as somebody who voted for the Affordable Care Act, let me say for the record, when somebody comes up and they say to me, Michael, because of the bill you voted for, I have to buy insurance that's too expensive for my family because I live in a place where there's not enough competition and the price is high, the deductible is too high. That is and when I call and I want my insurance, for some reason it's never there because they can have people stay on the phone longer than I can stay on the phone. You caused that problem, fix it. I say to them, you know what, your criticism is exactly right. We should fix it. Now is our opportunity to fix it instead of playing politics with the American people's health care system. Thank you, Mr. Chairman.
Thank you. And since Senator Cassidy is on the panel, our tradition is that the panelist can't question the other panelists in the middle of a hearing. So the next person would be Senator Casey.
Mr. Chairman, thank you very much. One of the more compelling pieces of evidence or testimony in this whole debate has been what we've heard from folks around the country, what we've heard from our individual states. We just had I don't know if Sarah has that pile of letters, but we had a series of letters delivered from the ARC of Pennsylvania, which just over the last couple of days, pretty hefty sum there. And then other letters that went to the Finance Committee from Pennsylvanians and other states. So we're grateful for that. I think the process here, I think even folks who were supportive of this Republican bill would say that the process isn't in any way commensurate with the gravity of the challenge and the scope of this legislation. I would incorporate by reference what Senator Bennett said about what's been happening in the Health Committee. Some of the best bipartisan work on health care, maybe in a decade, moving towards a consensus and having 4 hearings just on those very limited number of topics, nowhere near the scope of this bill, and yet we had 2 weeks of hearings, great bipartisan work. We should return to that, get that bill done, and then maybe I hope, move on to other issues. I don't think there's any question when you compare the hearing time either in the Finance Committee or the Help Committee on the Affordable Care Act. There's obviously no comparison. Once you get above one, of course, one hearing, you're above where we'll be tomorrow in this committee. 11 days of hearings in the Finance Committee over the course of the consideration of the Affordable Care Act, 26 hearings in the Help Committee, 147, the final bill incorporated 147 Republican amendments. So a stark contrast. And then finally, I'd say that in terms of process, we could move in that direction and have a series of hearings on this legislation or any other, but I know that there's a deadline that some want to meet, which I think is not the measure that the bill should be guided by, the September 30th deadline, instead of working over months on a series of hearings. I had a couple of questions that I just been wondering about, and I'll just throw them out more, I guess more statements and questions. What I can't understand is the obsession that Republicans have on this committee, and it seems across the Congress, against Medicaid, or the hostility they have to Medicaid. I don't understand it. It's gotten me very angry the last couple of weeks and months, because I care deeply about that program, to protect it, to strengthen it, to preserve it, that covers more than 70 million Americans, kids and people with disabilities, seniors getting into nursing homes. I don't understand that. And I also don't understand what is the big problem with 11 million people getting health care, in this case through Medicaid expansion, the balance getting health care through the exchanges. But why is that a problem? Why is that wrong? We all benefit when people gain health care coverage, and I think we're all diminished and, in fact, potentially injured when they don't. Do we want 11 million people to not have health care? Should that not be considered a measure of progress? Senator Toomey and Senator Santorum are here with us today, and I welcome Senator Santorum back to the committee. Know that in our state we have a huge rural population. We've got 48 rural counties out of 67. I spent a lot of time in the month of August going across the state, and a lot of those were those rural counties. And talking to folks there just about the opioid crisis, as Commissioner Miller, Secretary Miller, and others have said, just that alone is a huge challenge in rural areas. And in several counties, they said, thank God we have Medicaid expansion. Having the biggest impact on that problem, not a magic wand, not solving the problem totally, but people in Pennsylvania getting treatment and services for an opioid addiction problem solely because of Medicaid expansion. So I don't understand the obsession with winding down and ultimately getting rid of Medicaid expansion. So let me get to some questions, because I know we're limited time. We'll get another round. But I want to start with Secretary Miller. As Senator Bennett mentioned, you testified before the Help Committee, and when you reviewed the work that we were doing there, that you participated in along with governors and others, and then when you reviewed this legislation, did you find any evidence of the stability proposals that we were working on in the Help Committee? Did you find any of those in this bill, the Republican bill that we're discussing today?
Senator, the only provision that we discussed that I saw in this proposal is a reinsurance program that lasts for 2 years. But it's not going to be enough to stabilize the market without CSR funding, without the mandate, with the repeal of the mandate. Those things are going to seriously destabilize the market in 2018.
And just very quickly, I want to be observant of time, I'm over, but Secretary Miller, Pennsylvania expanded Medicaid. You understand that better than most. This plan would block grant the Medicaid expansion funding in 2019 and eliminate the funding entirely in 2027. Could you explain the impact this would have on Pennsylvania? And maybe on my second round, I'll ask Ms. Mann, if you could do that from a national perspective. Could she answer that question? How about a short answer? Can we do that?
People waiting, yes,
Ask
a very
consent for a short answer.
I think the impact of these cuts will be devastating to Pennsylvanians. The governor has done everything, and all of us in his administration have worked very hard to make sure we expand access to affordable coverage for as many people as we can. And when we look at, even if you look at the conservative estimates, whether we're talking about $15 billion or $30 billion, which is our estimate, any of that range is going to, those cuts are going to have a real impact on people that rely on Medicaid for their health care.
Thank you. Thank you for your indulgence.
In the short time that I've been here, we've had rapid escalation of the amount of time that senators are taking. I hope that some of the other people on both sides will reduce their amount to make up for the extra time that others have taken. Senator Warner.
Probably not. Thank you, Mr. Chairman. Let me just make a couple comments and try to get a couple questions in. One, I got to give the sponsors of this legislation credit for one thing. This is the most radical, the most audacious change in our health care system I think we've ever addressed. What started as an effort to do away with Obamacare, and let me add to the voices, at least on this side of the aisle, that will acknowledge there's a lot of things in Obamacare that need to be fixed and dealt with, has morphed into a dramatic deconstruction of a program of Medicaid that has existed for more than 60 years. And I'm not asking you to take some wild-eyed, Democratic, left-leaning liberal group. Let me just take American Enterprise Institute, a well-respected center-right think tank. Their quotation, as I go through the analysis, talking to the sponsors and supporters of this legislation, quote, they should be mindful of the public perception that the most important piece of domestic legislation in many years is being pushed through Congress before there is time to fully understand it or raise legitimate questions about it.